Okay. I don't know what this is saying.
Just probably telling you that we're recording.
Okay, got
All
it.
right,
Okay.
perfect.
So thank you. I'm not technically or very good tech savvy, I guess. So thank you everybody for joining. I'm going to be talking about obesity management and diabetes specifically. The data that I took from was the American Diabetes Association guidelines and Endocrine Society. So we know with obesity and weight loss, if you have, a modest amount of weight loss and you sustain that, you can improve your glycemic control and you can reduce your need for glucose lowering medications. Even if you're using more intensive dietary energy restrictions with very low calorie diets, this can substantially reduce your A1C and your fasting sugars and promote a sustained diabetes remission throughout at least 2 years. And we also know just losing weight will improve other comorbidities. Next slide. So today I'm going to be talking about your diabetes and obesity assessment, the diet, physical activity, behavioral therapy and pharmacotherapy, and also surgical interventions. Next slide. So when you're talking with a patient, you want to make sure you're very careful in the way you describe them. Lots of patients don't like to be called diabetics, but more a person with diabetes. And that's the same with obesity. You want to refer to them as a person with obesity and trying not to use any judgmental language and keeping the conversation patient-centered always. Next slide. So in your assessment, of course, most of us do the BMI calculation or our computers do it for us. But it's based on your height, weight, and we recommend doing that annually or more frequently, depending on how often you're seeing the patient. And just remember, the parameters for Asian Americans and very muscular or frail individuals will be a little different than our normal. But the BMI is starting at 30 and above for anyone other than Asian will get you the classification of obesity. And then overweightness is 25 to 29.9. And then it goes up from the 30 goes 35 to 40, and then greater than 40, it's class 3 obesity. Next slide. So you want to also make sure you're respecting a patient's privacy when you're performing the weight checks. I think this is probably something we all try to do just as providers. We try not to embarrass them and make sure they're comfortable with you. At your assessment, though, you also want to look at comorbidities, any unexplained weight gain or weight loss, or if their medical status is deteriorating, you may want to consider a more aggressive assessment. But you want to talk to them about their food intake, their medication usage, and their glycemic status. Next slide. Next slide. So again, making sure your care is individualized by considering what motivation things you're going to use. You want to also consider their circumstances in their life and their medical status. And, even just for an example, some people, they don't have access to maybe the proper types of food. So you really have to kind of work with them in order to get them to do the best they can in the situation that they have. But our goals are normally to get about at least 5% weight loss in patients with type 2 diabetes who are overweight or obese. That includes a lot of work on both ends. It includes us doing our jobs and giving a lot of motivation and recommendations, but also the patients doing those things at home on their own. So counseling, they recommend anywhere from greater than or equal to 16 sessions in 6 months, focusing on diet changes, physical activity, and behavioral strategies. A 500 to 750 kilocalorie day energy deficit for most women. This is about 12 to 1,500 calories per day, and men 1,500 to 1,800 calories per day. So basically, though, any caloric deficit, regardless of the type of nutrients you're using, should result in some weight loss. Next slide. So again, as I mentioned, you want to consider the patient preferences. You want to evaluate if they have the proper foods available, if they're hunger, if they're healthy options. You want to also include their cultural preferences. So in order to maintain weight programs, that we recommend that they sustain weight loss for at least a year or more. That's going to require, again, a lot of work, sometimes monthly support in just monitoring weight, their activity level. Sometimes I offer patients, if we can't get access to them as quickly, oftentimes I'll say, look into the community and see if you can get into support groups and things like that. But if you're going to do something more very low calorie, like 800 to 1,000 calories a day, you also it needs to be probably with a structured type program with people who are trained in doing those types of treatments. Next slide. I'm going to actually pull that up on my end here on my computer because it's kind of hard for me to read. Sorry, guys. Hang on 1 second. So this is just kind of reiterating this slide of when you want to start to intervene. And so even patients who are, a little bit overweight, you definitely want to always focus on their diet, their activity, and any behavioral things. And then once the BMI starts to climb, you might consider doing pharmacological treatment or metabolic type surgeries. Next slide. And you can skip over to the next one too. So when you're choosing any therapies, not just for diabetes, but other medical conditions, you also want to consider those that might have some effects on your weight. Weight loss meds are considered effective as an adjunct to diet, activity, and the behavioral counseling. So you want to make sure you're also talking with the patient about their risks and benefits. We feel the most effective type of medication management, though, is usually when you're getting at least 5% weight loss over a 3-month period. If they're not achieving those goals, you may want to reconsider what you're using. If they're not getting, when early response is insufficient, such as less than 5% over 3 months, you want to look at safety, tolerability, and also, again, like I said, considering doing some alternative therapy. Next slide. So in speaking of diabetic care, so we always know that insulin has been known to cause weight gain, but also the class of drugs called sulfonylureas. So you may want to think about if you're going to use those therapies or if they're needed, you might consider using them with other medications that help with weight, including metformin and GLP1 type agents. They suggest that ACEs, ARBs, and calcium channel blockers may be better for weight rather than beta blockers. Anti-epileptic meds, you consider which ones you're going to use. And also just steroids, if you're treating conditions that need some anti-inflammatory benefits, you may want to consider other things than steroids. Next slide. So the meds approved for obesity, they have ones that are short-term treatment and others that are long-term treatments. Next slide. So we have a number of meds. Remember, any of these classes of drugs are contraindicated in women who are may become pregnant or who are pregnant, and they must have some form of reliable contraception. So these next slides, you can go to the next slide. I'm just going to focus on all these agents individually. So phentermine, it's a norepinephrine releasing agent. The mean weight loss is about 8 pounds. The studies have been anywhere from 2 to 24 weeks. These are drugs that were approved in the 1960s for just short-term use. The things you have to worry about with phentermine would be uncontrolled hypertension, hyperthyroid, anxiety disorders. They're pretty inexpensive, but the disadvantage is there's not a lot of long-term data. Next slide. And this sort of goes over that. It reiterates that. It also gives the cost of the medication. So as you can see, it's not too pricey compared to maybe some of the other medications on that list. And you also want to make sure you're using the lowest effective dose, to get the benefit. All right, next slide. So this one is Qsymia, or topiramate phentermine. The mean weight loss on this is a little bit higher, 14.5 to 18.9. The FDA approved this for chronic weight management. Common side effects similar to the other, but you also have to worry about insomnia, dry mouth, constipation, cannot be used in pregnancy or breastfeeding or hyperthyroid states. The weight loss seems to be more robust, but it can be expensive and teratogenic. Next slide. And this is reiterating the cost. If you look at the cost there, it's pretty pricey. Okay, next slide. You may have remembered a medicine called Belviq or lorcaserin. This was actually withdrawn from the market. And the reason was due to risk of cancer, pancreatic, colorectal, and lung cancer. So we're no longer using this agent, but it was something used in the past. And I thought it would be worth at least mentioning. Next slide. Orlistat or Ally or Zenical. It's a pancreatic and gastric lipase inhibitor. The major problem with this is the bowel issues. You know, people get oily, spotting. They just are not absorbing fat vitamins very well. So that's probably the main setback, and it can be pretty costly. So if you go to the next slide, that'll show you the cost. $823 for a 30-day supply. So it's pretty pricey, but also it's not well tolerated just because of the side effect profile. So a lot of times, you know, in my experience anyway, I've had a little bit more trouble getting people to continue something along these lines. Okay, next slide. Naltrexone or bupropion or Contrave, it's a reuptake inhibitor of dopamine and norepinephrine, and it's an opioid antagonist. The mean weight loss is about 4.8%. It is for chronic weight management. You have to also be careful with this one with uncontrolled hypertension, seizures, drug or alcohol withdrawal. You would not want to use it in those types of conditions. Common side effects though, nausea, constipation, headache, vomiting, and dizziness. The advantages though, they get a greater weight loss, greater than 3 to 5%. And then the disadvantages would be, of course, your side effects and the price range. Next slide. Can be kind of costly, $334 for a 30-day supply. Okay, next slide. So liraglutide is a medication we use in the endocrine world. It's otherwise known as Saxenda. It is a GLP1 agonist therapy, similar to things that you've heard, probably Trulicity, Ozempic, Victoza. The mean weight loss is about 12.8 pounds. These drugs have been around for a while. We have newer ones on the market in the same class of drugs, and we do use them really pretty frequently in endocrine. Probably the main side effect is a lot of times expected to have some nausea with the way the medication works. It slows your gastric motility, so patients can feel a little nauseous. It's most times they can sort of work through it, but if it's bad enough and they're vomiting, obviously we wouldn't want to continue. I do tell patients though, you know, if you eat a little too fast and a big bulk at once, sometimes that can make the symptoms worse. So kind of slowing that process down can help. There is a black box warning on it for medullary thyroid cancer or MEN2 syndrome. It was found in rodents, not humans, but it is on the labeling. So I do like to talk to patients and just to let them know that there's a risk there. Although I don't really think it's a true risk, but it is with the rodents anyway. It can be expensive. And the other thing is these agents are given as subcutaneous injections. Next slide. So the GLP1 class, so liraglutide, Saxenda we just talked about, that's like Victoza. It does come in doses of 0.6 and it goes all the way up to 3 milligrams. The Wegovy is our newest one. It's like Ozempic. It can go up in higher doses. Right now, Ozempic goes up to 1 milligram, but this goes beyond, goes to 1.7 and 2.4 milligrams. The big thing with the Wegovy is that I haven't been able to get, it's on such back order that I haven't been able to get it for patients. And one occurrence I've had, the PEIA had declined my refill or my script because I didn't work at a weight loss center. So that's one stipulation they're putting on it now. But I think that's going to probably go away once the supply comes back. Next slide. I think I talked a little bit about this. There can be acute gallbladder disease with this class of drugs. As a side note, have I given it to people who have, I have given it to people who've had pancreatitis from previous like gallstone, whose gallstone has been taken out and they have or they've had a cholecystectomy. So if that was the true reason for it, I have tried it and it has helped and they haven't had recurrence. But Dr. Giordano, have you given anybody this class of drug who's had pancreatitis from maybe gallbladder disease?
I have. I forewarn patients, that it can increase the risk, and especially if it's a remote history, previously due to stones or whatnot. But I definitely do give them that kind of forewarning. And if they have symptoms, of nausea and vomiting, to call us. But I will say, how we dose it, Renee, I think it's helpful too, because if we start at a low dose, that typically causes less symptoms, and they can give us that warning, hey, I'm having cramping, stomach discomfort, before we get to kind of the higher doses.
Yes, I agree. So also on that list, hypoglycemia. So that's really if it's used with other agents that can cause hypoglycemia, such as insulin or sulfonylurea. But I always warn patients, like if you're on insulin and this medication works well and you lose some weight, you're going to be less insulin resistant, and your requirements for insulin will likely go down. So I try to make sure they're checking and keeping the eye on sugars very closely, so that if it does get to that point, my choice would be to reduce the insulin rather than to reduce the GLP-1, as long as they're tolerating it otherwise. The renal impairment thing, more, in my opinion, goes along with, if they're really sick and vomiting and they have some degree of kidney disease. If they're vomiting, losing volume, they can become dehydrated and can put them into acute kidney injury. So, those are the warnings I usually I need them to let me know, give me feedback if it's really bothering them, because I really don't want them getting into worsening of problems. Next slide. This just makes me crazy. The cost, the average wholesale cost is $1,500. Hoping over time that will go down. We have patients who can use patient assistance programs sometimes with the drug companies that lowers cost. But sometimes it's jumping through the hoops till you be able to get them what you really would like them on. But that would probably be one of the major factors, that if I don't have someone on an agent like this who would be a good candidate, it's usually for cost. Next slide. So Wegovy is the newer one, as we discussed, that just came out. It's the one that goes in the higher dose. It's like the Ozempic, same things we just kind of talked about. Next slide, and you can skip over that. So metabolic surgery, it's something you should consider in screening type 2 diabetic patients with a BMI of greater than or equal to 40 or 37 in Asian Americans. BMIs that are 35 to 40 who do not achieve durable weight loss and improvement in comorbidities, including hyperglycemia with non-surgical methods, and type 2 diabetes with a BMI of 30 to 35 who also do not meet those goals. Next slide. So you want to make sure, though, if you refer somebody, we have a center here at WVU. It's the Bariatric Center, where they basically bring our patients together in a group where they talk about surgical options, but also the medical management part. And then they can split up into groups. And if they do choose the surgical side, and if you're planning to refer, I would just make sure it's in a center where they do a lot of surgeries with experienced surgeons. It's going to be a thing where it's long-term lifestyle support and routine monitoring of all their nutrients, and sometimes replacing the things that they are then deficient in. They need to be evaluated for other comorbid conditions and psychological conditions and social situations that might impact the care. And they should have ongoing mental health services to help just the adjustments in doing this type of surgery and how it's going to affect them long-term in just their lifestyle. Next slide. So if you would have any questions, please feel free to reach out. I do like the next slide though, skip over, because it just makes me chuckle. But anyway, does anybody have any questions?
Thank you so much. I like that last one too. I wish it worked that way.
Me too.
That would be amazing. That would be amazing. I just ordered like Nutrisystem, so like cross your fingers, guys.
Okay.
Great
I think too, it's like, with just any of my patients, you really have to figure out like what works for them. It may not be medications. It may just be behavioral changes. It may be, okay, I have to have this in my diet. Well, you can have maybe that, but in moderation, or not, as infrequently, and just maybe a little bit. Like, I hate to tell someone like, you absolutely can't have birthday cake when it's your birthday. They just have to kind of account for it and maybe not do it frequently and, moderate your amounts. But the weight loss medications can help in those people who actually need a little bit more assistance.
Absolutely, 100%. Thank you so much. And I think in the last year, I think a lot of us could use some inspiration on weight loss. Like your freshman, 20? I feel like it's been like COVID 25 or something. Does anybody have any?
I would say COVID hasn't helped a lot of my people. And the depression has been bad. People, it's been hard on people.
100%. Yeah, and then some of those medications can also assist in weight gain. So it's a balance for sure.
It's true, yeah. And if you're depressed, you change your lifestyle sometimes because of that. It can interfere with control. Just keeping things in line.
Absolutely. Does anybody have any comments or questions?
I think,
go ahead.
well, I'm sorry.
No, you go ahead, Dr. Gardner.
I just wanted to say, I think that was such a great review with a lot of pertinent, great slides for reference. I will tell you one thing I learned from WVU just recently. We had a new nurse join us, and we have a screen in a place where Epic can keep track of kind of social determinants of health. And along the lines of COVID and all of us gaining weight and it being harder to kind of obtain groceries or get fresh groceries, I would also let you guys know, if you don't already, that there's this social determinants of health that can be viewed in Epic, where patients are asked about, how far is it to your closest grocery store? How far is it to get like fresh foods for you? Which I think is outstanding that those things are really being addressed in the clinic. And I just wanted to share that with you guys as well.
I did not know that. You'll have to show me that next time you're in the office.
Yeah, it's tremendous. I think the social determinants of health is really one of the biggest factors in everything we do. What we prescribe, what the cost is, insurance, but also these other things, like we call them food deserts in West Virginia. So areas where if a patient is living in a certain zip code, they may not have any fresh fruit or vegetable within a 2 to 3 hour radius, or like a 60-mile radius. And I think that is so impactful in how we help our patients. And it may not be, okay, is it a medicine that you need, or is it how do we help with you getting access to food, period?
Mm-hmm.
Do you have enough money to get food, and what is the food that you're eating, and can we even change that? I think those are really great questions that come from the social determinants of health that hopefully we can help with more in the future.
Do you guys happen to know of any meal delivery services that do that? I know at one point in Morgantown there was it was like a church that did it. They had to pick it up, but one day a month they could go pick up a box of and it included like fresh fruits and that kind of thing, and it was very discounted rates. Or do you guys know of anywhere that does that any longer?
I do not, but we could reach out to our social worker. I could even give you her name. She might know. Are you from Morgantown?
Yeah.
Okay. So it's Casey Tennant. She's really helpful in just kind of even helping patients get medications, but it's TENNANT. let me see if I can, I've got my computer here. Hold on. Or do you do my chart? Do you have my chart?
No, I
Oh,
wish. I
I'm
wish.
sorry.
We're trying, huh, Dr. Polywall? So our clinic's based in Fairmont. We've been asking our clinic to get the Epic, but so we're based in Fairmont. But if it was like a male-based program, you know, I would think that would be amazing. But
Well, if
Yeah.
you give the administrators your contact information and they can get it to me, I can get you her name and number, and she may be able to see, she may even know areas that are outreach sites from here that might be able to help you.
yeah, thank you so much.
Sure.
I know me personally, my kids and I volunteer at a couple centers. I don't know if they actually have anyone driving food to houses, but the centers that we just volunteer for in Morgantown that may be able to help you to see if they could deliver. So there's Christian Help, and then Pantry Plus and Ursula's are three places that I would start. They're both phenomenal. All three of them are really phenomenal food pantries. So you can start there. They may have, help with transport too, which I do not know for sure. We just typically do the stocking portion.
So I'm looking, there's something called Pantry Plus More. That's in Morgantown. It says no dine-in, so I'm guessing you pick up, or I'm not sure if they deliver. Christian Help, that's one you said, right?
Yep, Pantry Plus, Christian Help, and Ursula's.
Ursula's, yes, that's all the three I have listed here.
Yep.
Thank you.
Very great question. Thank you so much. Dr. Polywall?
Yeah, thank you for the presentation. And I mean, one of my question is like, usually when I encounter something like a medication or a referral that insurance will give me a hard time, I make a protocol. Like if I have to give a strong pain medicine, I have to document they tried Tylenol, NSAID, physical therapy, they did X-ray, MRI, and things like that before I jump to the higher thing. I try to maintain a protocol. Is there something like this that you try to attempt and you document so that when you try for medication, something like Qsemia or Contrave or Wegovy, that you document and that actually happens so that when you send the prescription, okay, and they need a prior auth, it will go through. Is there some kind of formula like this that you follow that you can share?
So Dr. Giordano, you may be able to help with this question. When it's related to the SGLT, or excuse me, the GLP1 agonist class, like your Wegovy and your Victoza, Ozempic, I'm usually documenting, the type of diabetes, if they have hyperglycemia, what their BMI is. Like I said, the Wegovy, I think it will be covered just because they're diabetic, but it's a matter of just supply. The other medications like Qsemia, I actually don't write for because I'm a nurse practitioner and there's some stipulations on how long those can be written for. So there may be a protocol, Dr. Giordano. Do you write those very often, or can you help out with this question?
I'm mainly talking about non-diabetic patient.
Oh, non-diabetic patients.
Yeah, in non-diabetic patients, I feel like we're really up against it. It's much harder. I don't think, and Renee said this best, Wegovy's not stocked well. Typically, weight loss medications are much more costly. They're not covered as well. But I would say for diabetic patients, what I typically try to do is if they're already on Ozempic or not on Ozempic, so now we know Wegovy is semaglutide, which is the same drug as Ozempic. So what I try to do is just maximize the Ozempic dose higher. And I tell them openly that it is not FDA approved for higher doses for treatment of diabetes. But we've seen clinical trials for Wegovy and weight loss, and that it can help at higher doses. And so I just tell them kind of the risks, which are pancreatitis, nausea, vomiting, constipation, diarrhea, And then I increased their Ozempic dose. There is a new Ozempic pen out. It used to be the 2 milligram per ml, and now they have out the 4 milligram per ml pen. So I increased the Ozempic under the umbrella of their diabetes diagnosis, and just tell them, you know, the dose of 2 milligrams weekly is not currently FDA approved. I think in the future we'll see that. But it's not currently approved, but I do increase that. And so that's kind of a, how do I say this nicely? It's kind of a trick that I use, you know, for help with weight loss in our diabetes patients who cannot afford or get Wegovy.
Have you been able to get it covered that way? They'll pick it up. You know, sometimes I wonder if,
Yes,
you know, if they'll deny it just because it's not the correct dose.
exactly. I tell the patient out front, it is not approved in the 2 milligram dose currently, but if you're willing to try it, and most of the time it's approved. I haven't really gotten anything that's been denied as of right now.
Mhm.
Along the same line, I mean, for patients who are like afraid of shot, just they don't want shot at any cost. Have you had any success with Rybelsus in terms of weight loss?
Yeah. Yeah, I actually had a patient today. She's doing really well on it. We started at the very low dose, so like the 3 milligram dose. And even at that dose, normally you may not see a whole lot of weight loss, but she's now on 7 milligrams and she's lost about 10 pounds. But it was the same situation. I kind of offered to her, okay, we've maximized your metformin and you need to lose a little bit more weight and get the sugar better controlled. And so she didn't want an injection and she was willing, and she did the Rybelsus.
Okay, thank you.
Yes.
Now, I know working with one of my preceptors back when I was in school did a lot of the pre-op type approvals for weight loss, like bariatric surgery. And I know she kind of had like a checklist of the things that she needed to get that covered. And so I wonder if you know, that's such an extreme option beyond these medications. Like it just seems like, do you ever see it get approved for, and like, I think of especially like Medicaid patients, does it ever get approved, even if we're documenting all those things that we can get a bariatric surgery approved for?
Yeah, I mean, I have had, Jen, have you had a decent amount of patients approved for it? I have.
Yeah, absolutely. I feel like sometimes, unfortunately, coverage is better for surgery than it is for medicine.
Yeah, that's what it.
Yeah. Yeah. And I think it's unfortunate, but I would say that when you have BMIs, you know, 30, 40, and Renee spoke to this really well in her lecture, the amount of weight loss that you're going to use in preparing your patients for the amount of weight loss is really important. So to say, you know, the average weight loss is 10 pounds or 15 pounds, which is amazing. And I think that should be congratulated. But ultimately, when we're dealing with, you know, a BMI of maybe 40, I think we need to consider that in the back of our mind too. And so the reason why surgery is approved maybe more effectively or better is a lot of the time because, you know, that degree of obesity leads to, you know, higher risk of cancers, strokes, heart attack. I mean, the obesity related conditions are endless. So, you know, I'm happy that it is approved, but you know, you're right. It's kind of like, well, why won't you approve the Rybelsus if you're willing to approve a weight loss surgery? I don't know all the intricacies of that because it's really dependent state to state. You know, it's very different insurance. But I do see that all the time. Patients get approved for weight loss surgery in the sleeve, but not like Saxenda.
Yeah.
Well, you know what I have found though, Jen, you may agree with this too, is like if I tried this 6 months ago to apply for certain things, these insurances change so frequently. I don't give up. Like I still readdress it. And then the drug companies are also really helpful sometimes in just giving patient assistance. And I think it's, if they make less than 61,000 a year, that they can help with like medications for diabetes. And usually the ones I'm using it on are these types of agents or Jardiance. But that's kind of how I just don't give up. I just keep asking the question. Just same thing for even like CGM therapy. I just keep going. Did it change again? Let's submit again. Just keep trying.
Thank you so much. That was really great. I'm not obviously a physician, but I'm wondering if it's like because is surgery kind of like a one time instead of like an ongoing thing? Do you think that's part of it? So it's not like a continuous, you know, event, I guess, like getting medicine constantly? Because you don't have to medicate after a surgery like that, correct?
Yeah, I mean, a lot of people can have remission of diabetes. So in that respect, I guess you're right. They're getting fewer meds like blood pressure pills and diabetes medications, but sometimes they still need them even if they regain weight and things like that. And then you're dealing with the consequences of surgery with like vitamin deficiencies and things. But maybe if you looked at it as a whole in terms of the cost analysis between doing the surgery and doing these medications, I don't know what would be less, but.
Is it risky? I mean, this is just, I didn't know how risky that kind of surgery is.
I mean, they have ones that, they have the less invasive type. They used to do the bariatric, the bypass surgery, but the sleeve, there's fewer complications. So, but every surgery, you do take some risk.
Excellent. Are there any other questions before we end our session or announcements? No, I think you're good. Okay, I'm going to do the poll thing. So make sure you do it, please. Volunteer, but please do it. And then the only announcement I have is our next session will be October 13th. Melissa Phillips will be discussing pituitary incidentinoma. I think I said that right, Loma. So we look forward to that. Was that okay? Okay, cool.
Pretty good.
Good. I Googled it, so
Incident.
Awesome. Thank you guys so much. I'll